health behaviour change. We thank everybody for taking the time to join us today. My name is Tara Hare. I am the current president of the Social and Administrative Pharmacy section of FIP, and I'll be your moderator tonight. We have two fantastic speakers to give us a very quick overview of this topic, but some housekeeping first. If you've attended any webinars prior to this, you'll be aware this webinar will be recorded and is also being live streamed on YouTube, and this recording will also be available on the FIP events website following this webinar. If you have any questions throughout the presentation, please ask those using the question box, and we are always happy to receive feedback, so please provide that through to the webinar's email at FIP. And again, if you are not yet a member of FIP, please do investigate becoming a member and look up our membership options at fip.org/membership. So tonight, as I suggested, we have two fantastic speakers. Ruben Viegas, who works for FIP and is the Humanitarian and Sustainability Program Manager, and Mara Pereira Guerreiro, an Associate Professor at Egas Moniz School of Health and Science in Portugal. So today, this is how we're going to run. Obviously, we're doing the welcome and the introduction by myself. Then we're going to get an overview of behaviour change in healthcare by Ruben. And then Mara and I are going to have a little discussion about the various things that influence and contribute to health behaviour change and how pharmacists can work with that. Then we'll have a short period of time for any questions that the members of the audience may have, and then we'll wrap up and conclude all within a lovely short half an hour. So the objectives of tonight's or today's session is to highlight the role that pharmacists can play in supporting patients' behaviour change, explore how the behaviour changes may actually lead to positive health outcomes, and then showcase FIP's work in area of self-care, including introducing our newest series of CPD Bites. So, for our very first presenter, I'd like to welcome Ruben Viegas. So Ruben, as many of you will know, is a wonderful participant and helper in the FIP world. He's been working for FIP for a number of years now and has progressed up to become the Humanitarian and Sustainability Program Manager. He is a huge asset to FIP, and his background in this particular area of practice is very well suited to this presentation. So Ruben, if you'd like to give us an introduction.
Thank you so much, Tara, for the introduction. It's indeed a pleasure to be here, and this area links to my area of expertise in my PhD. So health promotion and behavior change is something I hold dear to my heart. And what I'll try to do is very briefly just give a very basic and large overview of what will be discussed further, but then also what we can discuss in future events. And I just want to ask colleagues if they have any questions, just write in the Q&A. But also if you have any presentations or any research on the area, please also share in the chat so we can note and just share between the people interested in the topic. So moving on, why do we have to talk about behavior change? Because there are many behaviors that are not good for our health, and this is published, and we have enough evidence for this. For example, smoking. And why do people keep smoking? Well, I have the example, for example, of my mom that smokes for the last 30 years. And maybe it was because she started a while ago and she doesn't feel ready to quit. Maybe it's because when in the social circles where she goes, everyone smokes and it's a norm and she feels well in that. That there's a lot of behaviors that are ingrained in the society and that people just follow. They are maybe not aware that they can change, that they need to change. So behavior change is a tool that can be used to tackle these behaviors. And as you see on the comic I brought, is what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day? Because sometimes we only think about the behaviors, in the moment we're already too late to work on it, or that we need a major intervention to understand that that behavior or the behavior that we've been doing needs to change. So we talk about behavior change because there are several behaviors that affect our health and that we can tackle through different means. And following that is that there's already a lot of research in this area. So we have different models, behavior change, the transtheoretic model. So I won't go into detail on these models, but this slide is just to mention that there's extensive literature and research in this area, and most of these models are already used in healthcare as well. So you can easily find all this literature published on this area. Another aspect that I thought it could be interesting to mention is also motivation. So one of our videos that I'll mention afterwards will touch on this point of motivation, because there's, as you see on the right side, you have a spectrum of motivation, right? It can be more extrinsic. I'm doing it because I'm getting paid, or because there's something I want to do for someone else. Or if you go to the right side, it can be more intrinsic. So it's fun and I really want to do it. So this is where we want to go when we talk about behavior change, that patients do this behavior because they feel intrinsically motivated to do so. And on the left side, you have the hierarchy of needs, because there's also different needs and different, and people value these needs differently as well. So it's important to be aware that these needs link also to the motivation to change sometimes. Moving to the resources, there's also plenty of resources. I have a couple of books here. One of the books, I will put the link in the chat. It's a book from the next speaker, Mara Gray. It's an open access online book that you can access, but there's also plenty of other suppliers and online courses that you can do by yourself, meaning that's already plenty available, but that as FIP, we're also trying to build on this capacity. And that's why we're doing, for the self-care month, which is from 24 June to 24 July, we'll be launching 6 CPD bites, so continuous professional development videos. These are short videos between 5 and 10 minutes that talk about these topics. So one is about habits, the behavioral economics, what is it? One of the models that I mentioned before, the COM-B, then the stages of behavior change is another model, and then 2 videos about motivation as an overview, again, of this topic, because you can really go very much deeper into these topics. So these CPD bites are just scratching the surface on these topics. But of course, if you're interested, these are a good starting point, and then you can go and look more in depth into these topics. So I hope that this was a very brief overview of the topic, but gave you a bit of context for the discussion that will happen next. So thank you so much, and back to you, Tara.
Thank you, Ruben, for that little overview. What's going to happen next is Mara and I are going to have a little forward and back with a few questions focused on this area. Now, Mara has extreme experience in all of these topics. As you saw, she's written a book on the topic. So we're going to have a little discussion about behaviours, competencies, and how we can best work to help model these good behaviours and make behaviour change in our patients that we see. So I'd like to welcome Mara. I think we're both going to be on screen together. Now, Mara is from Portugal, and she is an associate professor, a R&D project leader, and an entrepreneur pharmacist. She has a PhD, and she's currently working as a researcher at the Egas Mona Centre for Interdisciplinary Research in Portugal. So welcome, Mara.
Thank you, Tara. First
And
off,
it's
I
going to
would
be
like
super
to...
fun, us being Mara and Tara, isn't it? So they weren't very creative with names. But
Thanks for that. Thanks for the introduction. First off, I would like to thank FIP for organizing this webinar. I'm delighted to be here today with you. I've been working over the last 5 to 6 years with behavioral scientists and using behavioral science. And my work has focused in translating that to provide the best possible care for patients and those living with a disease. So it's really great to have this space to bring us all together and to talk about the role of pharmacists in supporting behavior change. And I would also like to congratulate FIP for the CDP Bites, which I think are a wonderful initiative.
yes, they will be very useful. Now, given that you've done all this research and you've focused on pharmacist roles, what would you say the main competencies that pharmacists will actually need in order to help improve behaviour change and to focus on this area of their practice with their patients?
Mm-hmm. To address that question, I'm going to focus on the work that we did and was published in 2021, and it's a competency framework. And it's an interprofessional competency framework for health and other professionals to support behavior change in people self-managing a chronic disease. And of course, it is focused on chronic disease, but I believe it translates well to other areas such as disease prevention. So I'm not going to talk about the methodology, but it was an eDelphi that we use. So it's a consensus exercise. And we came up with 26 statements of competencies, and we divided those competencies into 2 groups. So competencies that directly support behavior change for the self-management of chronic disease, and foundational competencies, okay? And to put it very simply in terms of competencies, which was your question, Tara, if we think about the competencies that directly support behavior change, we're going to think very broadly about aspects such as having the competency to identify the behavior, having the competency to identify what influences the behavior for a certain person, having the competency to select behavior change techniques that are able to modify what influences the behavior, and then being able to implement those behavior change techniques. And when I'm talking about implementing them, is about having a care plan, as we are all used to do that. And it's also about the communication aspects. And in particular, being able to work with persons in a collaborative fashion, and using a person-centered communication.
Okay, so when you talk about collaboration, obviously interprofessional collaboration is a huge topic of interest at the moment and something that FIP strongly supports. So how do pharmacists work in this particular area to support behavior change in our practice? So we're working in our community pharmacies. How do you best see us collaborating with other health practitioners, for example, to achieve that goal?
Mm-hmm. That's a $1 million. It's a $1 million question, isn't it? Because as you mentioned, it brings us to the point of interprofessional education, really, because everyone. I mean, we hear a lot about collaborative models and how we should practice in a collaborative fashion. But I would say it's hardly the norm in any country, and that I've been, and particularly if you consider community pharmacists, which are pretty much the majority of the workforce in most countries and are like the most familiar face of the pharmacy profession for many citizens. I really, if we have a spectrum, for collaborative practice, I really think we are in the end of the spectrum where we're really beginning. So, as any complex matter, you require probably changes at an individual level and changes at an organizational level and also policy. But I think starting with what we academics can do, because I think that's probably easier, I would say to have a better focus on interprofessional education. Because if we look at the literature on interprofessional education that is out there, we see that is at best very patchy. So you have countries like the US, like Australia, like Canada, like a few countries in Europe where interprofessional education is more advanced, but still with very different models to implement. And that's fine because probably the context is different. But we still have some countries where the model is like a standalone activity in an entire term, for example. And of course, it's better than nothing. But at the same time, I think as academics, we should do better. I know, Tara, that in Australia, you have a policy context that is quite favorable for interprofessional education. So perhaps I return the question to you now.
I mean, there is some areas where it is quite good. However, once again, I think you have hit the nail on the head. If we start with students of all disciplines and get them learning and becoming familiar with that intercollaboration as a student and learning to, okay, this is a skill set that your colleagues in these other areas may be able to help with, and you should be reaching out to them. We're certainly seeing younger doctors are much more open to having conversations with pharmacists, but again, we still have the older traditional doctors and pharmacists who are very much, oh, that's not our job, that's somewhere else. So I think as time progresses and things move along, and I think everywhere can actually start implementing this within their education program and kind of introducing other disciplines to the skill sets and the benefits of particular professions having these abilities and working with them. Because as you said, pharmacy is in a unique position. We're the position where we're the most accessible, we're the most freely available healthcare professional, often for a long way, especially in some regional areas. Australia is a massive country. There are huge countries in Africa, and sometimes the pharmacy might be the only health professional within hundreds of kilometres. And so being able to have that skill and also having that connection that they can then reach out and refer people or get advice for someone who may not actually be able to go or afford could be very useful. So, I mean, I think we really got to work on building up these networks, and I think FIP is a great resource for that because we do have connections with other health professional organisations. So being able to use those skills to help, really drive this interprofessional collaboration can only be of benefit to patients and people globally. But what do you think is going to be the most important challenge to enable behaviour change interventions just at a primary care setting? So maybe speaking specifically perhaps about Portugal and then maybe expanding to how that could be expanded in other countries.
Mm-hmm. Well, I think actually I'm going to start with an European overview. We recently did some work with colleagues from Turkey. And what we did was we started with our competency framework, and we partnered with students' associations at the European level. And we tried to have a perspective on the level of implementation of education in behavior change support at an undergraduate level. And of course, it's a self-selected sample. It's not representative. Some of the results, and we have a poster about that in FIP in Cape Town for those of you who are interested. But the bottom line is, it is very patchy. It doesn't look as bad as we thought, but still loads of room for improvement. And I think what is the biggest challenge, I think it's education, really, and education of future pharmacists for a start. Because we know that this is all very difficult. We know that daily routine in a community pharmacy, it's pretty demanding. We have many demands on our time, and if people don't, if our colleagues don't have that capacity, then I think it makes it almost unsurmountable, really. So I always tend to focus in what I can do, and I'm an academic, so I think our role as academics is to build capacity in the future workforce so that they can tackle this challenge better prepared. We know it's not the magic bullet, but I think it's at least necessary. Then, so you asked me about what I think is the change that is needed, right? And I think education at an undergraduate level, I think it's a place where we can start. And then I think in terms of continuous education, many pharmacists, and in my case, I graduated 25 years ago almost, and I think behavior change support was just a topic. It wasn't covered in the curriculum. So it was pretty much about telling people what to do. And we know it doesn't work like that. We can have the best of the intentions, but really it doesn't work like that. And it can even backfire, because if we tell people what to do, you generally just raise confrontation, and that's not what we want. We want collaboration, building rapport, and having a therapeutic relationship with people. So I think in terms of continuous education, perhaps an FIP is doing that now with the CDB Bites, perhaps just having initiatives for those pharmacists that feel that is meaningful to improve their capacity, so they have the resources out there. And we have been working on this front also in terms of offering, and this was at a national level, offering health professionals and pharmacists in particular with courses, with CDP courses that address this area. And then, of course, we have the collaborative models that we mentioned previously, but I think that's beyond the scope of what we can do. But FIP and other organizations can perhaps lobby so that it becomes closer to a reality at a global level. And then I think the use of technology and digital tools, they are not there to replace pharmacists or any health professional. They're there to support our role, and perhaps, and this is also linked with digital health competence, but perhaps having pharmacists more aware of what technology can do for them in terms of supporting their role in behavior change.
You didn't mention funding. So, as we know, all these services are wonderful to offer, but they don't make money, generally speaking. And particularly if you're making a person behave and act in a way that they're going to take their medication and their health is going to improve, that's actually making the pharmacy less money in the long term, which is obviously what we want. But is there a role, for example, for someone like FIP to support local organisations to maybe put a case for funding or payment models from government or even private entity organisations to help, roll this along? Now, in Australia, we are very fortunate that we do have payment models for certain services. So things like diabetes management and asthma are two big and well-funded, supported by pharmaceutical organisations, doctors' organisations, and particular organisations and companies that provide these medications. Obviously, we are in a privileged situation that has occurred. However, in countries where, again, the pharmacist is, the primary healthcare provider for a number of patients, they may not have that ability. And if they have that huge volume of patients, their time and resources will be very limited in what they can provide. So what's your thoughts on, supporting that ground root, I guess, service implementation via funding from various entities?
Mm-hmm. That's a very important topic, because I think, of course, the way how pharmacists are remunerated in community pharmacy, it is an important driver in terms of the care you provide, and it's unsurprising, really. I think models are very diverse across Europe and at a global level. I personally think that having a service that is focused on behavior change, for me as a pharmacist with a background in community pharmacy, I'm not sure if that's the way forward. I'll try to integrate what is out there, because we support behavior change in specific contexts, like supporting medication adherence, supporting disease management, pharmaceutical care, clinical pharmacy services. I know there's an awful lot of terminology, and I don't want to go.
I mean, they're the basic
road.
premise of being a pharmacist, aren't they? That's what we do. That's us in a nutshell. So, are we making life more difficult by saying, okay, we want to be paid for this, when really it's an extension, really, of what we are trained to do? So I guess there's the double-edged sword. Can we do that, and is it going to take away from our other services that we provide, or is it something that people are going to take advantage of, take the funding, and not actually provide any additional services above what they're currently providing? So it's an interesting topic for discussion, and I think we can't really delve too deeply into this topic in half an hour, but that's why we have the CPD bites, because we'll go more deeply into the various topics on those. Now, I'm wondering if there are any questions that have been placed in the Q&A chat. Yes, looks like we've got some. Let me just see. Okay. We've got a good question here. What is the difference between behaviour and habits? And how would you differentiate between them?
A habit is a behavior that is sustained. It became something that is part of your daily routine. And of course, I'm not a behavioral scientist, so I'm only give you like a simple definition, but there's an awful lot out there that you can have a look at. And I think pretty much that.
Okay. Do you have any particular thoughts on hypnotherapy and its use in behaviour change? Have you had much experience within your research?
No experience whatsoever on that topic. My research is focused on translating behavioral science, and particularly using behavior change techniques to support patients in changing their behavior, either via digital care devices or by training professionals. So it's not a field of research I've looked at.
And then I think this is more. I think this is more a comment. But isn't there an underlying problem with the intention gap? Daniel Kahneman showed that system 1 and 2 thinking means most people are illogical and not deep thinking. As David Ogilvy said, people don't think what they feel, don't say what they think, and don't do what they say. I mean, I'd say that's a fairly accurate quote myself, because as we know, people are not always completely truthful with their health practitioners. I'd say they're probably more truthful with a pharmacist, but you can sometimes gain a lot of information from having a quick conversation with someone. I don't know if you've come across that mentality or that behaviour in your research, Mara.
Yeah, for me, Tara, is more when you're building a collaborative relationship with a person. If the person is not telling you the truth, perhaps that means something. So probably means that the relationship is not therapeutic. It could mean that the person feels that you are judging him or her. So I personally, and this has been, it's always learning and far from perfect, but for me, I think it's one of the most difficult things to build a therapeutic relationship with a person, because we pharmacists, I think we were trained to be efficient, with people, particularly in what comes to supporting medication adherence, but we don't think of emotions very often. And I think the inability to build rapport, to establish a connection with a person that comes to me as a pharmacist, I think this is where all those issues could stem from. So these are my thoughts on that brilliant quote.
Look, I think we've come to the end of our very brief time together. It's been a pleasure. And as we've heard, you know, pharmacists, we are critical frontline healthcare workers, most accessible, the most readily available to most people in most parts of the world, regardless of where you come from. So we, as pharmacists, are actually ideally positioned to play a crucial role in supporting behaviour change. We see patients more frequently than maybe other health practitioners do. And as Mara said, we have the opportunities to develop relationships with these patients and get them to open up and trust us. And that in turn can also lead to us helping create and supporting behaviour change and ongoing health improvements in these patients. Thank you everybody for attending today. Don't forget to look out for our new CPD bites, where we'll delve a little bit more deeply into each of these topics. So if you were very intrigued by this, stay tuned and keep an eye out for the rest of those. I'd like to thank Ruben and Mara for hosting this and for speaking. And don't forget, we have our annual Congress coming up at the start of September. It's going to be in the lovely Cape Town in South Africa. FIP Congress is always a great event. So if you've never attended, maybe consider coming to South Africa. It should be great. And we've also got a new campaign that FIP has just launched, Think Health, Think Pharmacy, very topical and pertinent to this particular webinar. So obviously we need universal recognition of our unique place within primary healthcare. So we're going to work through this with the Development Goal 3, with sustainable development, with good health and well-being for all. So support this campaign, because this will also help support policymakers. Again, something we briefly touched on. So go to the fip.org, Think Health, Think Pharmacy, and sign up to support that campaign. There's lots of pictures that you can put on your Facebook, and yeah, check it out. And obviously, FIP runs a huge range of digital events. If you've missed one, they're all online. So you can go to events.fip.org and catch up with something you've missed, or check out what's coming up in the future. There's always something for everybody on the FIP website. Thank you, everybody, for your time today. I hope you enjoyed the session, and we will see you next time. Thank you.